Okay, so now we're going to talk about how to take care of someone in labor. First of all, labor and delivery works a little differently from a med-surg unit or an ICU. We're used to getting patients on our units who either maybe they're direct admit, so they've been seen in a provider's office and they come in with orders, or they go through the ER and they come up with orders. Well, labor and delivery, we do our own triage. So the patient may walk in. When they walk into an ER, I promise you the ER nurses are shoving them on the elevator to L&D as soon as possible. They don't want to deal with any babies. So we get a patient, and the L&D unit is usually the one who triages that patient. So first of all, we have some basic triage questions. We want to know, chief complaint, what brought you in today? Are you allergic to anything? So we don't give you something that'll kill you. What is the gestational age? So if this baby comes out in the next 5 minutes, where is it going to be? Okay, are we 28 weeks? Are we 30 weeks? Are we full term? What's the gestational age? Has the baby been moving? Are you having contractions? Do you have any other pain, and do you feel pressure? Is anything coming out of the vagina? Are you having any fluid leaking or any bleeding from the vagina? If so, what does it look like? If it's blood, we want to know how much, because as the cervix dilates, there's some bleeding. It's blood mixed with mucus. It's called bloody show. But if they're having a lot of bleeding, that could indicate a problem with the placenta. So we want to know how much. We want to know if they have fluid leaking. What color is it? Is it cleared? Is it green? How much is it? Are you having any headache, visual disturbances, or epigastric pain? And that's because we're screening for preeclampsia or risk of that. So we also, while we're asking those questions, we put them on the fetal monitor. Okay. And then we might collect a UA. Some facilities collect a UA on every patient. They walk in the door, and if they don't look like they're about to deliver, go to the bathroom, change clothes, pee in a cup. Okay. Some facilities don't do that. We're screening for UTIs and for protein in the urine, which would also be another indicator of preeclampsia. Then the patient's put on the monitor. We ask our questions. And we probably are going to do a vaginal exam. Now, if the patient is suspected to be in preterm labor, especially if their water may be broken and it's preterm, we want to make sure we're following the facility policy. And that's going to depend on largely when doctors can get in. I worked in a teaching hospital that had residents on the unit at all times. Nurses did not do exams on patients who were suspected preterm labor. The residents would come do a speculum exam because that's lower risk for introducing infection. Working in a community hospital, when you may not have a doctor that comes in unless there's an issue and you're evaluating that patient, communicating with the doctor, and they may be sent home without seeing a doctor, you don't want to send someone home and have them deliver a preterm baby at home. So you might do a vaginal exam in that situation. So make sure that you're following facility policy for those preterm labor. And of course, we never do a vag exam if we suspect placenta previa. Now, you will also get phone calls when you're working labor and delivery, and people want to know what they should do. Follow facility policy. Ideally, the facility has a written policy procedure for telephone triage for labor and delivery. Be very cautious about giving advice. Always tack on, if you have any concerns, please come to the hospital, because you don't always get the full story by telephone, and you may give them advice based on what they're telling you. They may not realize something else is important, and they're not in front of you for you to see it, and so you may miss something important. So be very cautious about telephone triage. Typically err on the side of asking them to come in and be evaluated. Now, I mentioned vaginal exams. Vaginal exams are done with the index and third fingers. They're done to determine progress in labor. It's not necessary to do scheduled exams in labor. We typically do exams. When someone comes in, we want to know where they are. We're probably going to do an exam. We want to know if there's a change in fetal heart tones. We want to know if there's a cervical change that corresponds with that, if there's some change in the mother's symptoms, if they go from light, everything's good, to feeling a lot of pressure or the contractions get a lot stronger, we might do an exam. We want to do an exam before we give any pain meds, because if we give pain meds too close to delivery, IV pain meds, then the baby may be born and have respiratory depression. If the patient feels any pressure, an urge to have a bowel movement, or vomiting, they get an exam, because those are all usually indications of fetal descent, and they may be indications if they're ready to deliver. And we do an exam after rupture of membranes, unless they aren't in labor. If they're not in labor, then we're going to be a little more cautious. Who do we not do an exam on? Previa or possible previa. And we're cautious with preterm labor. We're cautious if the membranes are ruptured and they're not in labor yet. We want to get heart tones and make sure everything's okay, but we might not want to examine if we don't think they're in labor yet. And that's because that increases the risk of infection. Okay, what do we evaluate in an exam? You evaluate dilation, effacement, and station. We might also be able to tell the position of the fetus. So we're looking at dilation. How much is the cervix dilated? We looked at an image of that a few minutes ago. We're looking at effacement. How thinned is the cervix? And we looked at that a few minutes ago. The other thing we're looking at is station, and that's going to be where the presenting part is in relation to the ischial spines. So I'm going to see if I can find a good image of that. Here we go. Let's share this. Okay, so the ischial spines, you can see sticking out here. If you're doing an exam, you can actually feel them. And I will be honest, it is rare that we actually poke around to find those because it's painful. So when we're evaluating station, if we want to be really, really sure, we would do that. But a lot of times we don't need quite that much surety. We may be estimating this. So station is an estimate of where the presenting part is in relation to the ischial spines. Even with the ischial spines is 0 station. Every centimeter above is minus. So this fetus is at -3 station. Every centimeter below is plus. And that's going to be really hard to feel. You're reaching up on the side of the baby's head trying to feel these ischial spines. It's very painful. So we're kind of, well, this feels lower than it was last time. I think we're +3. We should be able to feel presentation, what part is coming first most of the time. We might be able to feel position if we can feel the sutures on the skull. Now, swelling, the bag of water, different things may actually get in the way of us being able to feel those, but we would also note that on assessment. Now, that's all triage, okay? A lot of times if someone comes in, they think they may be in labor. If they're on their initial triage assessment, they're determined to be in active labor, they're going to be admitted. If they are maybe in labor, or if we're not sure if they're in labor, they may actually be observed as an outpatient for an hour or so to see if they have any changes. So we may assess them as an outpatient for a bit before they're either admitted or discharged home. If they are in active labor or there's some other reason they need to stay, then they're admitted. At that point, we need to review the prenatal record for any risk factors. And we can actually do that during the triage as well, but we want to make sure when they're admitted, we review their prenatal record really well. We do an admission history and assessment, and that's when we get labs, start IV, etc. Okay, the next section we're going to talk about is fetal monitoring, and I'm actually not going to record a new lecture for you on fetal monitoring. So in between sections 8 and 9, there are going to be there's 3 or 4 sections that are recorded for the freshman student. So it's going to say 12-18 fetal monitoring, and it'll say baseline, etc. So I want to go through briefly what you're looking at, and then I want you to watch those videos. So fetal monitoring, we're monitoring contractions. We want to know resting tone, It should return to soft. If they have an intrauterine catheter, then that should be less than 20 millimeters of mercury in between contractions. And we're monitoring the frequency and the strength and the duration of those contractions. Frequency is beginning to beginning, duration is beginning to end of each one. Both of those may be arranged, they're not perfectly spaced apart. And then the strength can be measured by palpation if they have external monitoring, by the IUPC if they have one in place, okay? You should see a gradual increase in the frequency, strength, and duration of contractions through labor. They begin really spaced out, kind of wimpy. They get stronger, closer together, longer as labor progresses. Now, we're also going to look at the fetal heart rate baseline in the response to the contractions. The baseline should be, you just look and draw a line down the middle of that fetal heart rate squiggly line. It should be between 110 and 160. Typically, a higher baseline can indicate that they're preterm, or it can indicate maternal fever, or that they're stressed and they're not compensating as well. A lower baseline you may see with post-term, or you may see if they have some neurologic damage. A baseline change can be significant. If the baseline is rising, that may mean infection or impending distress. If the baseline is dropping, that may mean either serious sedation, or it may be some neurologic issue. Maybe they've not been tolerating labor well for a little while. Okay, so we look at baseline. Then we look at variability, and that's how much that beat varies from beat to beat, okay? So when you watch the numbers change on a fetal monitor, you'll see 120, 122, 124, 123, 121, 118, 120, 122. It varies a lot, jumps around a lot. That's normal. It indicates a neurologic system and that is competent in dealing with what's going on, okay? The variability is, we look at that in terms of the range. So if the range of that heart rate is between 6 and 25 beats per minute, that shows that the fetus is compensating for stress as well. So we call that moderate variability, okay? You're going to look at all of this in the previous recordings. I'm going to transfer them over, okay? Marked variability, if it's over 25 beats per minute, big zigzags, it can show an exaggerated stress response, but it does show that the fetus can respond. Minimal, less than 6 beats per minute range, so minimal variability, shows that they have decreased ability to compensate for stress, or it can also happen if they're asleep. If you've got minimal variability for 20 minutes and then it goes back to moderate, that's a sleep cycle. It can show sedation, so you've given them some Stadol and you see minimal variability, I would expect that. Or it can show decreased oxygenation. So we're monitoring that, but minimal variability is not a jump in and it's an emergency, okay? Accelerations, we want to see accelerations. The heart rate accelerates at least 15 beats per minute for 15 seconds. That's a reassuring response to fetal movement. I want to go back to variability. Absent, no variability at all is a very concerning sign. It generally means the fetus is barely able to maintain the heart rate and they can't tolerate any stress. Okay, you'll see all this in the video. I've got strips that you look at in the video. Now, accelerations, we want to see, that means the fetal heart the heart rate is able to respond to changes. They may have accels in response to movement, noise, contractions, or just randomly. Decelerations can have different meanings. Decelerations is when the heart rate drops below baseline. The first one we're going to talk about is earlies. Early decels occur with the contraction. They're usually curved, kind of a bowl shape. They dip and they go back up. They may look like a mirror image of the contraction. They always recover by the end of the contraction. Usually, this is caused by a vagal response because the head's being compressed, okay? They may indicate that labor is progressing, so they may be a good sign. They're generally considered a benign thing, so we don't worry about early decels. Now, I want you to think about what happens. We've got contractions, baby's doing okay, variability looks good. What happens if the cord gets compressed between, let's say, the baby's shoulder and the pelvis? What do you think would happen? Cord gets compressed, baby's fine, sudden change, sudden loss of perfusion. We see a quick drop, quick recovery. That's called a variable decel. They can occur at varying times in relation to the contraction. You'll see them most often with the contraction, but they can be before, during, after, in between. Okay, they're usually a sharp drop, sharp recovery. They may occur with moderate variability and everything else in the strip look great. They most often indicate cord compression. How that's managed depends on how severe they are and how long it is till delivery. So if they're having small variable decels, probably okay. If they're having deep ones, are they 8 centimeters or are they 2 centimeters? Okay, are they having with every contraction or now and then? So that kind of determines what the provider will do. Late decels are decels that occur regularly with each contraction. The decel begins after the contraction begins and recovers after the contraction's over. They can indicate placental insufficiency. So I want you to remember, I want you to think about, we've got the placenta, chorionic villi are down in the little lake of blood, okay? A contraction happens and there's still oxygenated blood in that space. So the fetus still keeps getting oxygenated blood, right? What if there's decreased perfusion to that space? Now, when I have a contraction, I may not have enough oxygenated blood left in that space to get through the contraction. So the fetus, partway through the contraction, the fetus kind of runs out of enough oxygenated blood and the heart rate starts to drop. Contraction goes away, oxygen comes back, heart rate goes up. But the heart rate goes up after the contraction's over. That's a late decel, okay? Now, usually they mean the placenta is not adequately perfusing, but that can be chronic. It can be from preeclampsia, it can be from chronic smoking, it can be because they just have really poor circulation for some other reason, or it can be acute. I've seen late decels when we start an IV and the patient vagals. Patient vagals passes out when you start an IV. What's their blood pressure? Their blood pressure is probably pretty low. So for a little bit, they don't perfuse that space below the placenta well. So we have late decels. We get that mom's blood pressure back up and the decels go away, right? I've also seen it when the mom's laying flat on their back, because all the blood, when you're laying flat on your back, blood goes to your feet. If you've got 15 pounds of baby uterus and fluid sitting there, that's compressing the vena cava. So the blood that goes down to your feet gets trapped and doesn't come back up. It's called vena cava syndrome. And I've seen late decels with that as well. Tilt them on their left side, those go away. So even though we're talking about placental insufficiency, it can be acute, something that's fixable, or it can be chronic, something that we're just going to have to see, can the fetus tolerate it until delivery? Okay. Management of lates also depends on how frequent they are, how persistent they are. Can we do things to make them get better? How far away from delivery? Okay. Now, the last one I want to talk about is a prolonged decel. It's a decel that's 2 minutes or longer. It can begin as either a late or a variable decel. And it a lot of times indicates that the fetus may struggle to tolerate labor, but if it recovers, they may watch and wait for a little bit longer and see what's going on. How would we manage concerning decels? That means deep or slow recovering variables, extended or prolonged decels, or repetitive lates. First thing we want to do is turn the mom to the left side. If they have variable decels and they don't recover, then we turn them to the right side. We flip-flop them, okay? For lates, they're always left. If they have Pitocin, turn it off. If they have a Cervidil in place, that's a med to induce labor that's on a little fabric tape, we remove it. We want to increase their IV infusion rate, unless they're at risk for pulmonary edema. We want to give them 100% oxygen, treat whatever the cause is if we can identify it. If it doesn't get better pretty quickly, we call the provider. And we want to report persistent lates, recurrent, deep, or frequent variables, or any extended decels to the provider. They have a fetal heart rate classification system, and I actually go over that in one of the videos I'm going to transfer to this section. So remember, you're going to be out of order. This is recording number 8. We're skipping 9. We're going to have, I'll probably put 9A, B, C, or D, and then we'll go to 10.